This is Dr. Anisul Awal from Chittagong. He is another very enterprising young cardiologist of the country, and he is very active in the academic forum. So please welcome Dr. Anisul Awal.
Assalamu alaikum and good afternoon, sir.
Thank you.
My case is a horrendous complication and smart management. My patient, Mrs. MB, she's a 60 years old lady. She's non-diabetic, non-hypertensive, and only history of betel nut. And she had actually inferior MI on February 21st, and she was admitted in hospital in Feni, where she resided. And she actually presented late there after 12 hours. That's why she received low molecular heparin there. And she presented to us with chest pain again in the month of June, more than after 3 months. And we diagnosed her as unstable angina on the top of old MI inferior. And echo shows there is regional wall motion abnormality and ejection fraction was 46%. We offered her angiography and she accepted. And we found that left main coronary is normal, free of disease, LAD type 3, good sized vessel, initial 30 to 40% stenosis, followed by 80 to 90% stenosis at the mid segment. And SIRC was non-dominant. And there was also 70 to 80% stenosis at the OM branch. And RCA is totally occluded after AM branch, and it's getting retrograde filling from the left system. There's the angiography. And as you can see, the right coronary is a tortuous vessel, and it is occluded from the mid segment. And the left system, as you can see, that SIRC is a non-dominant, and the LAD, there is a initial lesion and there is a mid lesion 70 to 80 to 90%. So we decided that to intervene, and we decided to open up the total occlusion first, and we take 10,000 heparin. And as angiography was done 2 days before, and I found that one of my junior fellow have done this, and there is some edema and there is scar. That's why radial pulse was not that much well. So I decided to take the ulnar one, and for this to see the contralateral, I take the femoral. So this it was ulnar and femoral, and guide catheter was JR3, 6 French, and we were take the Filter XTA and Sion Black, and we used several balloon for pre-dilatation, and we used 2 stents and also use post dilatation. So this femoral route, we take the shot from the left system, and ulnar to ulnar route we use the JR, and we take the Filter XTA where to cross the lesion with the balloon support. And you see the support was not great, so we have several times artery either disengaging or it's going more. So with the balloon support, we are finally able to cross the lesion. And we started very small balloon for pre-dilatation, and thoroughly we dilate 1.25, then we use 2 balloon, and finally we are able to visualize the vessels. And we found that this is a very diffusely diseased vessel. So then we took a very long stand, is 2.5 into 40 or 0 stand from the bifurcation, distal bifurcation to proximally. And we deployed the stand, and the stand view we check how is our result. We don't have IVAS in our center, and we use for post dilatation another 2.5 short balloon for post dilatation. So we are thinking that we are in a winning situation. We open up the vessels, so our job is done. Maybe we'll go for the LAD one, or there is some proximal, some dissection, and we are thinking that it's not flow limiting. Should we stand or not to stand? We are thinking like that. On that time, we actually lose our, to try to increase the vessel support, we actually lose our wear and disengage. And we found that we are in a disaster situation. This is you can see there's a bad dissection and ugly dissection. And you see, I'm in a position that I lose my wear, my catheter disengaged. Initially, I have a lot of pain to engage this vessel. So again, where I'm trying to engage is not possible. It was every time it is not sitting there very well. So I'm in a very tense situation. What to do? Patient is crashing on the table. She's having chest pain, and I just then think about that. Why not to go to the femoral route? So I try to use the femoral route, and now I able to engage the artery very easily, and I able to cross the lesion and the stand now. And without any delay, I took a very 3 size 3x40 stand to cover the up to ostium and overlapping the stand, and I deployed the stand. And what we have done after deploying the stand, I took another balloon 3.5 and post dilate, and able to actually seal the dissection. And you can see the final result here. So CTO lesion attempted and end up with a dissection, and finally able to manage it by putting another stand. So dissection, artery dissection is a fatal complication, though it's very rare, 0.3 to 4%, and requires early recognition. Aortic dissection may lead to complications like MI, death even. And right coronary is more common than the left main, but left main is more fatal. And there are several types of classification. A to 6 only if we see can speak is there A, and if you see parallel tracks is B, and if you see the extraluminal cap is C, spiral filling defect is D, and there is persistent filling defect is E. And there is another classification more simplified, localized dissection or Jekyll-like dissection when it comes to the branch, or when dissection comes extend up to the aorta. Our case is the type 3, it's come up to aorta, and as there is hemodynamic instability 100%, cardiopulmonary resuscitation 100%, and could be death 100% if you cannot timely intervene. So fortunately, we are able to done that. For doing challenging complex cases in a resource limited needs logical approach, perseverance, and teamwork. Complication may appear at any time like tsunami, and one need not to be panicked. Cool-headedness, logical approach, and prayer all might help. Right coronary ostial dissection is a rare but grave complication. Immediate recognition and prompt stenting covering the stand origin dissection may be the bail-out procedure. Thank you very much for your kind attention.
Thank you, Dr. Anisul Awal. It's a really nightmare in the lab, and you have managed the patient very well, though I am not very sure whether there was a surgical backup on standby in your center. So are there any questions from the audience or?
Sir, I have a question, sir.
Yeah. Please, Dr. Momen.
Yes, sir. Thank you, Dr. Anisul Awal, for your courageous case and well managed. Did you follow up the patient with CT autography or other?
Yeah, we had the plan to do the CT autography, but that is not in our center. And due to patient lockdown is coming, patient was hastily leave the hospital. But we have contact with the patient. She is okay. We have done the case in June 22nd. Yesterday, I also talked to the patient. She's symptomatic. So we had the plan to do the LED, and on that time we'll also check the right. And if she stays in Chittagong, actually I had the plan to do the CT autogram to see any extension there.
Dr. Maski and Dr. Arun Maski, would you like to comment?
No, thank you. That was a good case. One thing you should remember is once you have a dissection, you should always check and do echocardiogram. That will also guide. Sometimes you may have effusions. These are very pericardial effusions are very important. You have done a good case, tackled complications nicely. And best thing is during cath lab and after a patient is transferred to coronary care unit, you need to check whether there's any pericardial effusions. You may not notice that one. So otherwise, it's a very good case. Congratulations.
Actually,
Okay,
we did
there was
no pericardial effusion.
Can I attention, Dr.
Dr.
Bijoy
Anis, I have a question for you.
Yes, sir, please.
Bijoy Bang?
Not with us.
Anis?
No, he's connected. Dr. Bijoy Bang from India, you know. He's a senior professor. Dr. Bijoy Bang.
Probably his.
Okay, I think he.
May I put a question, please?
No, yeah. Moderator wants to know something.
Okay.
Professor
Yeah,
Khaled,
Dr. Anis, what
Yes, sir,
are
please.
the indications of referral to a surgeon in aortosteal dissection?
Oh, very good question, sir. If I am not able to cross the if I don't have the wire in the true lumen, if I don't have the confidently say that my wire is not in the true lumen, and if I am not able to cross the dissection plan, then there is a indication called the surgeon. or if ischemia wise, if it is a very large vessel and also the territory is large and also the hemodynamic instability.
Dr. Anis.
Another indication is that
Yes, sir.
more than 4 centimeters. If the dissection extends beyond more than centimeter, it is a surgical management. It should be preferred. Yeah. Okay. Thank you.
Professor.
Yes, Dr. Anis, what is the possible reason for your dissection?
That's right.
Thank you, sir. It possibly my guide actually was deeply engaged, and if you notice, sir, there is a small dissection in the very beginning. We did not really notice that, and it was sealed by the catheter. When we disengaged, then it's extend actually. That's we retrograde.
That may not be the explanation only, because if it is in the proximal RCA, not in the ostium, because it should be the catheter induced ostial dissection. If it extends beyond the ostium, it means that actually what is happening there, that the dissection, that is true that you have undermined the proximal dissection. The most important thing what you have done, the antegrade, the contrast injections, what you have given again and again, that one has a possibly also extended the dissection. So whenever you will see a dissection, it's better not to give that much contrast or forceful contrast to the vessel until unless you are sure that the dissection is not propagated antegrade. So this is
Okay, thank you.
Dr. Anisul Awal, before,
Yes, sir.
before leaving the cath lab or before withdrawing the guide, keeping the wire, take a good cine to see the distal vessel, to see the proximal vessel, whether I have done any wrong by the wire distally, whether I have done any wrong by the stent, distal to the stent, proximal to the stent, or by the guide ostium of the vessel. We shall have to evaluate it before leaving the wire, and it's a must. Otherwise, you will be in problem. If your wire was inside the RCA, then you will not be so panic, and you will have not such pain. You will be able to overcome very nicely, and that is one important point. Thank you. Next, please.